Are you sure that we're recording on your side? Yes. Cool. All right, guys, we're going to continue on. We're going to be on our fourth bullet point in today's study guide. And we want to go over SOPs, which stands for your standard operating procedures for your O2 tanks. Things that we want to understand is how to put these on correctly and then when to change it out, right? So let's see if we have
Made it.
we just started, ma'am.
Hello.
Hello. You're okay? So with the O2 key, we would open and close up here. And do you guys have a Leatherman? Just because there's no key in here. No? Alright, this is empty. A Leatherman, like a tool. Alright. So putting this guy on, this is just going back to your skill sheet, right? You're going to make sure that there's no dents in this bad boy, right? Typically it's going to have a little, like a plastic tab right here. You'd rip off, right? Making sure that green is going to be your, what? Oxygen, green, right? If this is yellow, that's medical air, right? You'll see both on trucks, all depending on what type of truck you're on. If you're working with a nurse or a CCT medic, it's possible that you may see a yellow, and medical air is going to be used more often with your pediatric patients. And we just have a mix of ambient air with medical grade air. So with this, you're going to go ahead and pull off. You're going to get your regulator here. This is not going to be an ALS regulator. An ALS regulator that you guys will see on a truck is going to have, and you guys should have had this at the Green Valley location, it's going to have almost like another spout that it has thread on it. Do you guys know what I'm talking about?
No.
No? Okay. I know that we're recording. Hold on one second.
No worries.
How have you been?
Good.
How was Griffin Hawaii?
Amazing.
Did you get married out there?
No.
Hawaii's awesome. A little bit out there.
We went to Oahu. We did parasailing, jet skiing. We did some hikes.
Nice.
First time cliff jumping ever.
Ever? Damn.
I was scared, but
It's
whatever.
all good. You lived.
Yeah. And then I thought I tore my MCL or
Oh.
meniscus, but I'm better now.
So an ALS regulator is going to have this guy. And this is the spout that we were just talking about. It has this threaded spout. You're able to screw on, it's a pigtail. And that pigtail can now go into like a ventilator, right? Some of your different brands of CPAPs will have that as well. So you may see these on a regular ILS truck. But then when you're working a 911 truck, you'll have these guys. Okay? As now you're going to put this on, of course, you're going to match up, right? Just like a little puzzle going in. You'll go ahead and tighten down. And then, if I had a key, but I don't have a key, we would want to open up, release any pressure, right? Clear any debris. This is now closed. Then we would take that key, open it, right? Lefty loosey, righty tighty, just the same. You'll have some, all depending on who your lab instructor was, all depending on how we were taught, right? A lot of us like to open it completely, right, all the way, and then a quarter turn back. Were you guys taught that way in the lab?
They just said open as much as you want to.
Okay, so you'll have two ways. You can just open it, right, or you'll have that old school way of thought of opening up all the way, quarter turn back. Nothing's really wrong. When this is completely full, this should be at what? 2,000 in the green, right? For those of you guys who've worked fire or going into fire and you're going to do your own O2 refills, if you do it too fast, if you fill it too fast, it'll say that it's full, but in reality it's not, because when it settles, and now because filling this up creates friction, right? It's heat expands. And then when you go and sit this, right, now it's off to the side being ready to go out and service again, and now it's colder, it may not be full, right? So that's why it's always important to take a look. Even though it was tagged that it was full, sometimes it's only showing it 1500 full. And it's important to know what you're going out with. You're going to check for any leaks, right? Now, when to change this is
500.
500. What page is this on?
Seen it was 5. I think it was 419. No, 421. Yeah, like 420.
So 420, 421?
Mm-hmm. I think.
So let's find where this is, where it actually shows the page number. 419?
Yep. 2,000 PSI.
Is full?
Yeah, two-stage regular will reduce pressures. Versus 500. What are we looking for when it's empty?
When you need to change it, because this is going to be up to you, right? As an EMT, when I'm working with my partner, right, and I have somebody on O's, I look to see that I have enough in the beginning, but then at the end of the call, right, I expect my partner, when they're cleaning up, that they take a look at how much is left and that they know when to change it.
So how long do you think it lasts?
So we're going to get into that in just a second.
Okay, because this says most EMS systems consider cylinder with less than 500 to 1,000 PSI to be low, too low to keep in service.
Correct. Right? And when must we change it? And that was on page what?
419. Oh. What page was the one I just read?
Mm-hmm.
420.
421. So on 421, down at the bottom, on the, was that the right column?
Mm-hmm.
It said that most EMS services will change it out between 500 to 1,000,
Yeah.
all depending on what's going to happen, right?
There you go.
So 500 is going to be when you change this guy out, right? That's going to be completely empty. That's going to be right here, just above the red, right? So 500, there's no way that you're going to be able to do much with that, right? But all depending on what type of truck you're on. So if you're working with me as a CCT and we're running CCT heavy that day, we're expecting to now have another ventilated patient, we can't go out that low, right? So I may have you change it at 1,000, right? So it's all depending on who you're going to be working with. Does that make sense to you guys? But SOP wise, right? 500. So always make sure that you understand who you're working with, what type of calls you guys are going to be running, right? If you guys are running as an ILS truck during this chapter here, which is going to be chapter 10, ILS is going to be your intermediate, right? Intermediate life saving, right? Advanced life support, right? Intermediate life support, advanced. If you guys are just doing nasal cannulas, going to 21 to 28, up to 44, 46%, right? You can have a lot longer time span with 1,000 PSI. But if you're going to be working with ALS and now you have a CPAP patient on transport 1 and then transport 2, you have somebody on a non-rebreather, right? That 1,000 is not going to work because now we're utilizing more liters per minute. Does that make sense to you guys?
Yeah.
So just always look to see who you're working with, what type of truck you're on, talk to your partner, and figure things out from there.
You started or what?
We are. Yes.
Is this paramedic or?
No, these are your future partners right here, EMTs.
Cool.
Yes.
What are you guys studying?
We are studying airway at the moment.
What are your stuff?
Yes.
Got this.
It's very possible that you'll be running with him very soon.
Okay, guys.
Take care. Good to see you, Ken. Do you guys have any questions with this?
So, how long do you think it will last?
So there's a whole formula,
Right.
right? So it's all depending on how big your the question is for you guys at home, how long would it last? It's all depending on what type of
So just
cylinder you
one
have.
use- One use of the non-leader takes out how much
well, it's 15 liters per minute, right? But as you can see here, this is a perfect example, right? This is going to be a total different equation. They're all based on the size. So this one here, right, running at 15 liters per minute may get you, without doing the equation in my head, maybe 20 minutes, but this guy over here can get you 30, right? So it's all depending on what size you're using, and there's a whole equation for that. Are we all okay in terms of what to expect for
Do we
O2?
know this equation?
No.
Okay.
No, at this point, no. As you continue into advanced, yes.
Gotcha.
Cool? Any other questions with this? You guys need to know everything about your O2 cylinders, right? The colors, all that good stuff. You missed when you were walking in. Green is O2, and yellow is going to be medical air.
And there's only two.
I'm sorry?
There's only two.
That you guys are going to see. There's multiple other
Okay,
colors.
medical air is usually for pediatric.
Correct.
Okay.
What was our next bullet point, guys?
It's going to be duty to act versus negligence versus malfeasance.
Right, so duty to act, malfeasance, and negligence. And that should be in chapter 3, I believe.
Chapter 3, page 97 to 98.
97 to 98. So duty to act is what? The duty to act is your duty to act.
To provide patient care.
Provide patient care. So let's say your start time is 1300, right? You clock in, right? You're on shift now. You're out there in uniform, and you receive a call. You now see a patient, let's say, who has maggots. Right? Did I show you guys that video? It's fantastic. Right? You would think it would be like 5 maggots. It was like thousands of maggots. I'll show you in a moment.
No.
For those of you guys who want to see.
I'll see it.
Right? So, for that patient, right, you have a duty to act. So you now have a duty to help him. If for whatever reason you just can't stomach it, you now have to conduct yourself in a professional manner, right? Not making him feel subhuman or however it may come across, right? And maybe ask your partner, like, hey, I can't even stomach this. I feel like I'm going to vomit, right? Can you please take this? In a nice professional manner. But one way or the other, you guys must help him. You can't be like, oh, you're gross. You can't go in my truck, right? That can't happen. Duty to act. Where it gets kind of strange is, let's say you're out at 3 o'clock in the morning, right? So 0300, you're out. You now go to 7-Eleven for a Gatorade, right? Gatorade and some gum. You're standing in line, person behind you collapses, cardiac arrest. You're in uniform. What is the general perception,
You know, so you know what to do.
right? You're in uniform. People don't care that you're not on shift, right? So when you're in that type of situation, and again, this is all going to be like, you're going to ask medic 1, hey, would you do something? Medic 2, and they may say no, right? Always do the right thing. The right thing is you're there, you see it, you know what to do, you help, right? And you have to understand what the community's perception of you is in that time. Does that make sense? Right? And now it does change. Let's say you have an undershirt, right? So you take off your duty shirt, right? Leave it in your car, you put it on the hanger and it's hanging there, and then you go in, right? General perception is you're just another civilian,
Yeah.
right? Oh, I don't know if you know how to do CPR. So now this is going to be on you. Do you want to work under the Good Samaritan law, right? Or not? And again, you can ask person A, B, C, and you can have multiple answers, right? In my opinion, if you're there and you know what to do, help, right? In my opinion, it's the right thing to do. You can ask someone else and they'll say no. But that's me.
Yeah.
Do we understand?
Yes.
Right?
Why
If
would
you're,
they say no? Why
well,
would they
you
say no?
can't leave, right? You can't leave until someone else comes. There's multiple reasons why people have that opposite opinion, and that's completely fine, right? But in this town, we're not obligated under the Good Samaritan law. We're protected under the Good Samaritan law, right? So why not? Let's
Also,
do it.
something bad happens, then we're supposed to.
So long as we work under,
our
like you shouldn't,
scope practice.
correct, you shouldn't have your own jump bag, for instance, right? You're just gonna be doing, like, you cannot acquire equipment to make your own jump bag. Does this make sense?
Why?
So you can't like grab a BVM from the trunk of your car, right? You're not on duty, so why do you have any equipment,
Hmm.
right? You shouldn't have any medical equipment. You look confused.
I'm not confused, I just think it's very interesting.
Okay,
If that's a way to save someone's life. you
but
have to
then
have
you're
it.
acquiring medical equipment when you should not.
So
it's
just
not-
an average person should just never have that.
Correct. Like you can of course have shears, right? You can have trauma shears, right? You can have a knife. You can maybe have a window punch, right? But to like break out a BVM and an OPA, right? Or a whole IV kit, like why do you have all that? Make sense? So you're just gonna work under the general practice of CPR in that type of situation. What is gonna be your malfeasance? And what page are we on? What page was our duty to act?
97, 98.
97, 98. Duty to act?
And then there's negligence too.
Yes. What pages are these on?
Negligence is on 98 too.
So negligence is on 98. And what is negligence?
Failure to provide the same care.
Right? So this is where it gets kind of interesting. If ever you guys are put on the stand, right? Somebody's suing you. Totally possible. They can sue us, me as Kristen Woods, or they can sue me as Kristen Woods, including whomever I'm working for, right? And when that happens is they'll take now somebody of my same schooling, right? So they'll take another medic, they'll take another CCT medic, right? They'll get all of your endorsements and they'll be like, okay, this person has this card, this card, this card, this card, right? So we have 5 people with the same cards that she has. She neglected to bag this person on scene, right? She says it was because of whatever my reasoning is. These other 5 people with the same exact endorsements that she has said that they would not make the same decision that she did on scene. They would have bagged her, right? They would have bagged this patient. That is going to prove that I am negligent. If now all 5 of the other people say, no, I totally agree with Kristen, right? I would have done the same exact thing. I wouldn't have done anything, right? She was rigored. She had rigor mortis, right? Lividity, decapitation. So no, I would not do that. I would make the same decision. Then I would not be negligent. Does this make sense to you guys?
Mhm.
Cool. And then malfeasance, what is that?
I should be familiar with this.
Yeah, I couldn't find that. Would that also be abandonment? No.
No.
I don't
Is it
see
AMC?
that word.
No, it's spelled correctly.
Okay.
But we don't have it.
It's not in-
Defamation?
it's not a word,
Okay, go ahead and look it up. Google it.
Wrongdoing, especially by a public official.
Right? Wrongdoing. Right? Malfeasance. Wrongdoing. So let's say that, and this happened just a couple of years ago in Arizona. If somebody has a seizure, for instance, right? That person now comes out of the seizure and they're typically in what state? a postictal state, right? That postictal state is usually like a caveman, just survival mode, right? I don't know where I'm at, right? I have no idea what just happened to me. And now I have 4 people standing around me. They're all dressed the same. They're not dressed like me. I'm on the ground. They're standing up. And now it's ready to fight, right? It's just survival mode, right? In that type of situation, would we now become overly aggressive with that person, right? Is it possible that we have to put hands on the person because now they're trying to fight us? Or for instance, somebody who's in a diabetic coma, right? Not even a coma, but now they're just altered. Let's say the sugar is 45, right? They're cool, pale, diaphoretic. That's typically your state for a hypoglycemic patient, right? And they're looking around and they have now no idea what's happening, but everyone's coming towards them. They don't have enough sugar to correctly think, right? But now everyone's coming towards them. It's ready to fight. And that's very common what happens. And that's the same thing from male to female. And we do have to, yes, put our hands on them, not in an aggressive manner, right? But hey, we're going to go ahead and we're just going to hold you down, right? I have your hands right here, right? We're just holding you down because we need to get this IV on you, right? We just checked your sugar and it's 45. You're low. You're talking to them the entire way, right? You're maybe putting them down on a couch, right? Where they're still able to sit. But you have a person on either arm, right? Holding their arms down so that you guys don't get punched, right? It's totally within reason. You would not drop kick this person, for instance, right? They go to punch you and you punch them, right? That would be inappropriate. So malfeasance can be now something that you're now overstepping your boundary, right? We should always remain safe. Yes, you guys will see that you guys have to put people in restraints, right? You have to hold people down, sometimes just for a second, right? Until they can get that sugar up. And now they're like, what's going on? Oh no, my sugar dropped again. I'm so sorry. Did I hit anyone? Right? It happens. And they should not be leaving that situation with like a bloody lip. Right? Are we all okay with this?
Yeah.
Malfeasance. You're only going to work within your range. Right? If let's say you guys have a patient who is 75 years old. You have a 75-year-old woman who has a history of dementia. Right? And she is now not in her right mind. And this happens. They start swinging. Are you going to drop kick grandma? Absolutely not.
We'll push her.
Right? You're not going to push her, right? You're not going to do anything, really, other than, ma'am, I'm so sorry, and you're trying really hard to be very gentle with her delicate little 75-year-old wrists,
Yeah.
right? She should not leave with a broken arm, right? Malfeasance. Are we all okay with this? Cool. Our next one, guys, is what?
Positive versus negative pressure when speaking of respiration.
All right. Positive versus negative. Oh, and can we... Let us go back to the O2. It just dawned on me.
Yep.
We're going to go back to, what is the bullet point number
4.
for the long transport time? Long transport time, what should we consider?
What are you talking about?
I don't remember which.
You consider how bad their necessities are, so determine which hospital to go to closer one.
Okay. Okay, which number? You're right. That is one thing. Which number are we looking at? Sorry, I'm using both my... 22? Okay. So with 22, if we can jump to 22 really quick. 22, and how is it worded?
It says, what should you consider when transporting a patient on O2 long distances?
Okay. And then let's go back to our pages that under airway management.
419.
419 in there. It's going to be in that chapter, everything that we should be considering. Right? So for long transport times, we want to think. Now, if we have someone who is on, let's say, a nasal cannula all of the time. Do any of you guys have family members at home who are on O2?
Yeah.
You do?
My dad.
Okay, perfect. So tell me everything that you know about his...
He only had the O2 after coming to the hospital, but he has a CPAP machine.
Okay. So CPAP machine for at night
Yeah.
when he goes to sleep. Okay. Does he have like a nebulizer or anything at home?
No.
No? Do any of you guys have it? Okay. Does she use it all the time?
Mhm.
So it's constant.
Not all the time, just when she has really a lot of breathing problems.
Okay. So let's go ahead and think of this, right? If this person now has this nasal cannula in here, and let's say they're normally on they're normally on 4 liters all day, every day, right? They're a COPD patient, okay? And with that 4 liters, their normal SpO2 is, we'll say 91%, right? If you constantly have 4 liters of oxygen blowing into your nose, what do you think that is going to occur up here? In the nose.
It's going to.
If you constantly have wind going into your nose, what do you think is going to happen? All day, every day.
You get used to it, or you get dependent on it.
Rotate mucous membranes,
Which page?
423.
423.
Cause dryness.
Right? Causes dryness. Right? All day long causes dryness. You're just blowing more and more air in there. So what do we have to consider?
The transport time, and consider the use of humidification.
Right? So when you go to now patients' homes, right, and they have their machines that are pretty big, right? They're plugged into the wall, right? And now they have little dials up here. And then this O2 is now coming over here, right? Typically, somewhere over here, you now have a little humidifier, right? So you should always be aware of when you go into somebody's home, hey, how are they using this? Because especially now, if this person, they call 911 for a bloody nose, and let's say they're not using their machine, they're just using a portable tank, because let's say they lost their power,
Yeah.
right? So now they have no power, so now they just are using portable tanks. These portable tanks, everything's flimsy on it, so you don't have a chance to put a humidifier on there. And now they're calling for a bloody nose. You're more than likely going to think this bloody nose is secondary to now irritated mucous membranes, right? So you should always take a look at people's setups. Consider transport times, right? If you're not going to be going to Utah, right? Ground, it happens all the time, right? You're going to be with this patient now for 4 to 5 hours, and they're supposed to be on 4 liters. Now you want to start thinking to yourself, how am I going to make this person as comfortable as possible? Now keeping their oxygen saturation at their norm, right? So before you leave these situations, you always want to ask RT, respiratory therapist, hey, do you have any suggestions that I can do since I'm going to be with this person for 4 to 5 hours? Should I consider a humidifier, right? Would you, oh, you think I should? Can I go ahead and get a setup? However is the best way to go about this. Make sense? Also, for those long transport times, you guys will see when you guys are starting your shifts, you guys should have 2, and they're not as big as this. The ones that you guys will see on a truck pretty much come to about here, right? But you should have 2 portables, and then you should have your main. And your main comes in different sizes. It's all depending on the truck that you're in. Sometimes they're like really tall, right? And super skinny. And then other ones are not as tall, but they're wider. The diameter is wider, so it's all depending on what size tank you guys have. But you should always be making sure that you have enough portables to include the portables to change out. You should have 2 extras plus the one on your bed plus your main. So you should have 4 tanks at minimum, right? Especially for these long transports. Because if you guys are going from here to Utah and you guys run out of O2, right? And now this person is static at 88% for the last 20 minutes of your transport time. That's now 20 minutes of 88% saturation
In the brain.
of their brain. So now, if they have any sort of anoxic brain injury, it is all your fault. Make sense? So there's a lot of things to consider as we're thinking about the SOPs. And that goes hand in hand with number 22, you said?
Yep.
22. All right, so going back into negative versus positive. I've drawn this a couple times for you guys, and hopefully now it's clicking. But if this is going to be your trachea, right, and you have the majority are just C's, and you have one complete circular ring, which one is that?
The
The cricoid ring, right? The cricoid ring is the only one that's a complete circle. Everything else are just little C's. You now have the bifurcation, right? That bifurcation means that the trachea now splits, it bifurcates into two. And you have the straighter right side and the loopier left side. Right? And it's loopier on the left because our heart is just slightly positioned more to the left. Then you have your lungs. And then we have our diaphragm down at the bottom. And that diaphragm is a 60 to 70% workhorse of breathing, right? Our diaphragm is going to be controlled by our phrenic nerve. Phrenic nerve, do you guys remember reading that? Right? Phrenic nerve controls your diaphragm. That phrenic nerve comes from C3 through 5. So if you guys can remember C3 through C5 to stay alive. Right? If now we have a high cervical spine injury, if you guys remember back to Superman, Christopher Reeves, when he had his horse accident, right? He broke his back, his neck, including at C3 through C5. So what was he dependent on for the rest of his life? The wheelchair for sure, and a ventilator, right? He had a little portable ventilator on that wheelchair. Without that ventilator, he wouldn't be able to breathe, right? His diaphragm was now no longer working because he had an injury so high up in his C-spine. Does this make sense to you guys?
So if the injury is above C,
So if it's in between C3 and C5, you have a very big possibility of no longer being able to control your diaphragm.
got it. But if it's above, there's a possibility. you
Correct.
can, and if it's below, there's a possibility.
Correct.
C3, 5 through 5 is where you're screwed.
Your phrenic nerve. So C3 through 5 to stay alive. Cool? As we're looking at this here, continuing, the other 30 to 40% comes from our accessory muscle usage, right? So that's going to be our ribs. That's also going to be our supraclavicle. Now everything is opening and closing, almost like a billow, right? When you guys are now trying to start a fire, make it bigger, you guys have to put oxygen on it, right? So now you have to blow on that little thing. You guys know what I'm talking about? Maybe? It's almost like this strange, like accordion looking thing. Right? And there's little handles up here,
Oh, gotcha, yeah.
and you're pushing on it,
Yeah.
right? And now it's feeding that oxygen, right? To make that fire bigger. The same concept up
Oh,
here,
the fire, yeah, gotcha, yeah.
right? Like a fireplace,
Yeah.
right? You're trying to feed it. And that's what your accessory muscle usage is going to be doing. So when we're thinking now of negative versus positive, the easiest way that I can tell you this, right, is going to be when our diaphragm pulls down, right? We're now pulling down on these lungs to make them bigger, right? When now your lungs are getting bigger, this is now creating a negative pressure. We're pulling down. Down is negative. Negative pressure, lungs are getting bigger. This is inhalation. We good? When we relax our diaphragm, and now the diaphragm pushes up, right? Now it's taking more space, and we're pushing up on these. We're now pushing up on our lungs, pushing all of that air out, right? And up is going to be a positive, right? Positive pressure. And this is going to be for exhalation. Does this make sense to you guys? Yes? Negative versus positive. And you have 30 to 40% with your accessory muscle usage, and 60 to 70% from your phrenic nerve that controls your diaphragm.
You said 40 to 70?
30 to 40 for accessory, and 60 to 70 for your diaphragm. Cool. And this is first talked about in the A&P chapter, and it's talked about again in your airway management in chapter 10, I think it is, in this book. So I think it should be chapter 6 and 7 and 10. So make sure that you guys go back through, read that. Any questions here? Yeah? I don't know if anyone's at home. No one's on? Okay. Our next point.
How to apply nasal cannula, non-rebreather, and how to assist the BDM and when to apply CPAP.
Okay, so nasal cannula, right? Nasal cannula, you guys are gonna see like we just drew a second ago. All right, this little guy is gonna go in each nostril. You guys wanna make sure that when you guys turn it at a side view, so a sagittal view, they almost have a little curvature to those prongs, making sure that they go in and not up. Right? And there's always like a little tab down here. Right? Make sure that it's down. They're gonna go behind the ears. Right? And then they come down here. Chin. Then it goes down here, and then we can cinch it up. With the nasal cannula, we're gonna typically on an ALS regulator, right? What we talked about earlier, those regulators go by 2. So it starts off 2, 4, 6, right? 8, 10, 12, 15. So with those ALS, you're gonna put these nasal cannulas between 2 and 6 liters. If it's a non-ALS, right? Or pediatric, they can start as little as a quarter. And that's going to be for your little neonate that, let's say, had to spend the first week in the NICU, and he comes home on oxygen. He's going to be at a very low oxygen setting, right? But he has a different regulator.
So in the book it does say 1 to 6, does it matter?
On the ALS.
Okay.
On the ALS regulators, right? On the non-ALS regulators, they'll go as small as a quarter, and then it goes like a quarter, and then it goes half, 3/4, and then there's your 1. And then they can go, but then they'll stop at your 6, right? They don't go as high as the 15. So it's all depending on which regulator you have. So on an ALS regulator, typically it's gonna go between 2 and 6. This patient has adequate breathing, right? Adequate breathing. They're warm, pink, dry. They're not in shock, right? They, let's just say, have a low O2 saturation of 93%, right? They're warm, pink, dry. They're complaining of, let's say, a low-grade fever, and a little cough, right? So you're thinking, oh, this person may have pneumonia, right? And you go ahead and you put them at 2 liters. They still say, oh, I have a little bit of a hard time breathing, right? So you bring them now up to 4. Oh, that's perfect, right? They're breathing adequately. As soon as that person is not breathing adequately, and whenever you guys see inadequate breathing on your exams, you guys will always think inadequate either equals non-rebreather or BVM. So inadequate, you're now going to put that mask over them, right? Pinching it at that little bridge of the nose and then cinching it around, making sure that that bag is inflated, right? Before you guys put it on the patient. If that bag is not inflated prior to, what are you gonna do? So this is a non-rebreather. You guys will see that they have little discs up here. So now when we inhale, these little discs, they fall flat on the plastic part. So the only thing that this person's able to inhale is what's here, right? So if this is not full, you can actually suffocate this patient, right? So that's why it's important to put your thumb right there, however you were taught with your finger. Make sure that this fully inflates, and then you put it on the patient, right? And for National Registry, you can go 10 to 15 liters per minute on these.
Yep.
This patient's gonna be cool, pale, diaphoretic. They have an increased work of breathing, right? It's obvious that they're in distress. If now this patient has head bobbing, right? Or they have an oxygen saturation of, let's say, 80%, and they're only breathing at 8 times a minute. Are you going to put them on a non-rebreather? No, right? Let's say they're breathing at 40 times a minute. Are you gonna put them on a non-rebreather? 40 times a minute?
No.
Because they can't control.
They're going too fast,
Yeah.
right? So every single breath, you have to think of it as almost like a tier, right? They're only getting down to tier 1. So let's make this 3 tiers, just for ease, right? If this person is breathing at 40 times a minute, he's maybe getting halfway through on tier 1 for oxygen before he's now pushing it out, right before he's exhaling. So what we want to do for this guy is to breathe with him, but now every, how many times should we be bagging an adult? 5 to 6 seconds, right? So every 5 to 6 seconds, we're going to allow him to breathe at his 40 times a minute, but every 5 to 6 seconds, we're going to push that inhalation, so we have to time it. It's a little difficult, right? So this person's, and now you have to breathe with him. So when he now inhales, right, we're now going to push his little tiny inhalation, and we're going to try to maximize that going all the way down to the third. Does this make sense?
Tidal volume.
Correct. We're increasing tidal volume at this point. We're all okay with this? Cool. So the difference between non-rebreather and bagging, your bagging patient is either going too fast or too slow, right? They're completely inadequate in terms of rate.
So if someone's hyperventilating.
So you have to be careful with this, right? Hyperventilation is a little different, right? Tachypnic is going to be what we want to think of. Tachypnea, which is going to be fast breathing. There's a difference.
So for the non-rebreather, it's either when they're going too fast or too slow, so they just keep like mixing it up, or
The non-rebreather is going to be that person who's cool, pale, diaphoretic. They're hypoperfusing, right? But this person is still, let's say they're at 20 times a minute, right? Your book will say anything lower than 8 and anything higher than 30 we want to bag, right? In between, we're thinking of non-rebreather. Do you guys remember reading this?
Not necessarily that one.
Yeah.
Okay. So as you guys are reading your airway management, make sure that you guys are looking for the numbers. Cool? And put it on your group me for each other. For the CPAP, this patient now has more than likely fluid in here, or they have mucus buildup. Right? So this person has CHF, for instance, with the fluid, also known as Rales. Right? They can have pneumonia with all of the mucus. Right? They have a low saturation. The thing with this person is he's still working to breathe, but now we just have to increase their pressure. Right? They're with it. They don't want you to bag them. If you guys can imagine feeling uncomfortable trying to get an inhalation and then get it out, and then to think that somebody has to now breathe for you, it just makes you more anxious, right? So now this is going to be where we put the CPAP on, and that just has continuous positive pressure, right? That's now pushing, all depending on what you're using, but you can go from a 5 to a 20 peak, right? And oh gosh, I don't have the ability to get my phone, but let me may I use someone's phone? And I'll put this on GroupMe so you guys understand what I'm talking about. Oh. And do you have YouTube, sir?
Yeah.
Have I shared the PEEP video with you guys? So copy link. And then your GroupMe. And Franklin's going to be sharing this. But if you guys want to look at this, so our intrinsic, so our natural PEEP is 3 to 5, right? But when everything's wet down here in terms of your alveoli, right, they shrivel. So if you guys take a look at that video, when you now have positive expiratory and expiratory pressure, we're keeping those alveolar sacs open, right? So we're not allowing them to fall with every exhalation, but we're keeping them open as we're exhaling and then inhaling. And it'll make more sense
Was
when
that
you
real?
guys... What's that?
Is that a real lung?
It's a horse lung.
Horse horse.
Mhm.
But do you see that?
Yeah.
How it stays basically popped open,
Yeah.
right? And that's what we're looking for with these patients, so they can still diffuse, right? As we're now trying to get this water back on the other side, right? We're trying to push it back into circulation instead of having it just pool there in the lungs. But this patient has to be awake, alert. They can't be nauseous, right? Because this patient, we're now going to have this, it almost looks like a Hannibal Lecter mask, right? And it goes around their head and it pushes, right? It has to be a perfect seal. There's no air escaping. So if this person now is nauseous and now they have to puke, we're just going to have that person puke, and then it's all going to be pushed back into their lungs, right? So no nausea. They cannot be hypotensive, because what is happening here is we're now creating more pressure in here, right? So 3 to 5 is our intrinsic, but now we're keeping it. So let's say this person is normally 3 on their side, but now we're moving it up to 5. We're putting more pressure within this lung, and we're pushing on the heart, right? So if this person is hypotensive, let's say they're 88 over 48, and now we're putting more pressure on the heart, do you think that's going to get better or worse? If we're putting more pressure on the heart? Worse, right? So now if we put this person on a CPAP, we expect now their next pressure to be 80/40. And that's why we don't want this person to be hypotensive. So you want to make sure that you guys have a good blood pressure before putting them on CPAP. Does CPAP make sense to you guys? Per National Registry, you guys can consider CPAPs. Per your local protocol, you guys will not be able to. That's a medic skill. Right? And that's only because these people deteriorate, right? They have a potential to deteriorating to the point that we have to intubate them.
If you do it wrong.
Or if they just are, if they get sicker. Sometimes that happens. May I see this?
So what would be like in the actual like that key that would tell you to have to use a CPAP then? So they're not.
So this person is the key. So if you guys can't hear on online, the key to using a CPAP, this person looks at you, they're tracking, they have a good GCS, right? They're alert, but this person is now, right? You listen to lung sounds and they have fluid down here, right? And you ask what their medical history is. Oh, I have CHF, right? I have congestive heart failure, right? That person is now going to be placed on a CPAP. Cool. And you look at their blood pressure. Their blood pressure is typically going to be high, right? So this person now has, let's say, a 170/90, right? Perfect candidate for a CPAP. Yesterday we went over 8, correct? Understanding how the heart works.
Yes, yes.
Yeah. So let me just write this in another way for you guys. Instead of drawing, for those of you guys who may be confused with the drawing. So we'll start over here at the superior vena cava or the inferior vena cava. Then goes into the right atrium, gets checked by your tricuspid valve, goes into the right ventricle, gets checked by the pulmonary valve, goes into the pulmonary artery, lungs, and this is where we have now plus O2. We pick up the O2 here. Goes into the pulmonary vein. From the pulmonary vein goes into the left atrium, gets checked by either the mitral or the bicuspid valve. Then goes into the left ventricle, gets checked by the aortic valve, goes into the aorta. Your aorta then starts to split up into all of your arteries. Those arteries then split up even further into your arterioles. We then feed the cells, right? And this is going to be through your diffusion. And your diffusion occurs here as well, right? So diffusion from high to low, diffusion from high to low as well. And this worked out perfectly. Diffusion here. Now we have to pick up the trash after feeding. So we have to pick up our plates, if you guys can think of it like that. The venules will be our first busser off that table. Then we bring them to the veins. And then the veins start all over at either your superior vena cava or your inferior vena cava. Does this make sense to you guys? Does it make more sense this way as opposed to drawing it?
Both ways.
Both
Yeah,
ways.
well, the fact
Yeah.
that
Okay.
the fact
But
that
it's
we
nice that
saw
we
the
have, now we have
drawing,
both, yeah.
Yeah.
Especially-
For
the
sure.
fact that we saw the drawing kind of
You can follow it.
it better. Yeah.
Cool. Yeah. And that's going to be how your heart works. And you guys can see where your lungs, right, come in. So it's just one big circuit.
Sorry, man. This is building B, right?
Yes.
Wait. Whoa.
Whoa.
Hold on.
Whoa.
Take it easy.
Take it easy. Let's see here.
Can you move it? Can I move this just
Yeah.
a tad? Sorry.
Yeah, I was just looking at the phone too. I don't think it's. Does it look choppy still on your end?
It just maybe it's just the quality.
Yeah, one of your other classmates said the same thing, but then said that the YouTube is easier.
Like if you do full screen, it's okay.
Uh-huh.
Like when it's smaller, it's a little choppy.
Grainy?
Yeah.
Okay. You're the second person to say that.
See, then now it goes away. Now it's see how much choppy again?
Yeah.
I don't know.
Okay. It just takes about a day for everything to go to the YouTube channel, which is strange. Are we good? And the I heard that the exam is now open, right?
Yes.
Okay.
I scheduled it already.
And that closes the 16th because grades are due, so make sure. Yeah.
And then are you gonna input the LC writing?
Yes.
Okay.
Inadequate versus adequate breathing, signs and symptoms, and how to treat in both adults, peds, and understand the difference between spontaneous breathing and versus adequate. So we have talked about the difference between inadequate versus adequate breathing already. Are we okay with that? Right? Adequate breathing, the person can still have a complaint of shortness of breath, right? But they still have a good chest rise and fall. So their tidal volume is still okay. Right? Inadequate breathing, they now have inadequate tidal volume. So inadequate chest rise and fall. It's either way too fast or way too slow. Right? Either or. Yes.
Now, if their respiration pulse, everything, BP is fine, but their SpO2 is not, then
So with their SpO2, we'll get into that with COPDers. Right? COPD is going to be opposite. So if this person is a non-COPDer, then we want to start low. So the question is, what if the person doesn't have a complaint of shortness of breath? Right? And there's a couple different things, and this is also in, I think, chapter 10 in your book. If, let's say, I'm outside, right, and it's January and my fingers are cold, right? My SpO2 may not read correctly. It may read in the 70s. Right? But I am warm, pink, and dry at my core. My fingers are cold. Right? So you warm up that person's fingers, and then you'll have a better SpO2 reading. So you have to understand your environment as well. Or let's say I have really thick acrylic nails on as well. Right? I'm warm, pink, and dry, but my SpO2 is reading low. That's because it's not reading through the acrylic. Right? So you have to understand. And all depending on which type of monitor you're using, there's like a jacket, right? It's almost like a sleeve, right? So you just continue down, get off that nail bed, and then you'll get a better reading. So all depending.
is it better or worse when you sit or stand? Is it,
All depending on what's going on with the patient. Yeah. But let's say this person is warm, pink, dry. They have warm extremities, right? So their fingers are nice and warm, but they're still reading at 93. They're not a COPDer, right? You can go ahead and put them on 2 liters, right? Just bump it up to 94. Hey, how do you feel? Oh, I was feeling a little weak before, but now I'm feeling better, right? Always ask, because shortness of breath, if somebody's hypoxic, and that's what comes in with this, if you guys can tell me the signs and symptoms of inadequate breathing, what page that's on?
It says in adults,
In adults.
195, 196.
195 and 196. You guys want to know your signs of inadequate breathing, right? So somebody who is weak, nauseous, dizzy, lightheaded, right? It's not always going to come across that, oh, I have a hard time breathing. Sometimes people will tell you another thing, but it still means that they're not perfusing well, right? So does this answer your question, Paige?
it does.
Okay. And then with peds, what page is that going to be on?
Good question.
I have my dad. they're always just freaking out about their health and like, oh my gosh.
Mm-hmm.
So my dad is one of those people who will check his blood pressure and then check it again. And he's like, oh my gosh, it's high. Oh my god. You know?
Yes.
So no one should give him, you know, an SpO2 but he has one. And so he'll check it and it'll be a good, you know, 95, 97, and then he'll check it a minute later, just 5 minutes later, and it'll be lower and he'll freak out. So I'm always confused when I see different numbers. and I'm
So
wondering
if he
what's
just
going
walked
on.
around, or if he is now anxious, right? That could be another thing. Is he holding his breath, right? You'll see that when people are anxious, they almost guard and they don't breathe. They're like, right?
Yeah.
They're not breathing with a full tidal volume, so that can also change.
Okay. Because I'm always curious on how little of a difference
Mhm.
is actually.
Yeah, and you'll see that people vary. You know, they'll go from 94 to 100% within an hour's time, right? Are they talking, right? Are they crying? Are they just sitting? Are they resting, right? Are they sleeping? That's another thing.
So if you're more stressed, your SpO2 might decrease.
It might, yeah. And even if you go to sleep, right? And if you're someone who snores, right? We were talking about CPAP. When people go to bed, they have to have that because now they have sleep apnea, right? So there's a bunch of different reasons. And we're looking for inadequate breathing
I
in
think I found
peds.
it. Oh, did you find it or no?
No.
Look at 328. I don't know if that's one you want.
Spontaneous respirations, shallow, yes.
328.
Shallow respiration.
Yep, retractions, accessory muscle, nasal flaring, perfect. 328 is also going to be another page that you guys need to go over, right? So on these pages, right, especially for 328, we have to understand that the difference between our pediatric patient versus our adult patient is not always going to be, oh, it's a tiny adult, right? We have to be aware that our 1-year-old doesn't have as many muscles, right, that our 22-year-old has. So now when this patient maybe his chubby legs. And then we also have to be aware that they have a big ol' head. Their head is 25% of their body, right, for our infants. And it's all back here. So when now this kid almost looks like an alien, but this is pretty much what happens. They have such a large head. We want to be aware that we should be padding behind here, right?
On the shoulders.
Behind the shoulders, right? And that's to now fix this big occiput. We also want to be aware that, hey, this kid doesn't have as many muscles in their accessory muscles, right? So their little ribs, they're supraclavicle. So now, and they don't have a lot of muscle in their bellies either. So now the diaphragm right here is now going to, it's called seesaw breathing, right? Now they're just looking, it looks almost like this, like a seesaw. So this is your little seesaw right here, right? This is exactly what it looks like. Seesaw breathing, as opposed to now having a bunch of accessory muscle usage that's noticed, right? These guys, their nares, so their nostrils, right? Typically that's going to be like your little nose right there. But now when they have a hard time breathing, they're now going to look like little pigs, right? That diameter opens, right? Same thing in adults will happen, but more so with these guys, right? If you guys think, if this is now a 6-month-old who still breastfeeds, and always think of it like this when you guys have this question on a test, how does a child eat? Nose or hand or mouth? The mouth, right? So if you guys can imagine now the 6-month-old, right, attached to now a breast, right? Does this kid ever, have you guys ever seen a kid drink, right, breastfeed? They never detach, right? They'll sit there attached for 10 minutes, 15 minutes, right? All depending on how fast and how good of a latch they have, right? And never let go. Because they are what type of breather? A nose breather, right? They're a nose breather when now everything is fine. Make sense? But now let's go ahead and take this same kid, and now let's say that he has a 3-year-old brother who goes to daycare, and everyone in daycare now has a cough, right? Runny nose. You guys have all seen these little guys,
Yeah.
right? And it gets gross, right? You have that bright green snot coming out, right? Everything gets all crusty, and now mom is trying to figure out how to get him. If you guys don't have kids, it is, even with like a 2 or a 3-year-old, it's hard to tell them how to blow. A lot of them will just kind of like, right? And you're like, no, with your nose. It's really hard. So imagine how hard it is here. So now you're constantly having to suction this kid, right? Do you think that now he's going to show signs of respiratory distress when now he is trying to latch on and eat,
Yeah.
right? He's only going to be able to latch on for a couple seconds at a time and then start crying because now he's uncomfortable because now he can't breathe. Make sense? So these guys are totally different. So when you guys are reading these pages here, make sure that you guys are aware. The jump kit, where is that at? What page?
I just read it was like 14 something.
14 something? Excuse me one second. Oh.
It's around 13. Look around 1380s. 1384 or something. Or 83.
Now you just the summaries and stuff. Said jump start kit?
Jump kit.
Jump kit.
I hope you guys eat Chick-fil-A.
Now what?
I hope you guys eat Chick-fil-A. It's being delivered right now for us.
Oh shit, thank you.
Did you really? You said jump kit, right?
Mm-hmm.
1359, I think it says the jump kit.
5960?
Yeah, 1359.60, I guess.
60? Okay, so what exactly is a jump kit? 59,
Well, everything that's
13,
in there is
59.
60, yeah.
60. Alright, so jump kits, guys. What exactly is it?
Says containing anything you need in the first 5 minutes with the patient.
Yep. First 5 minutes, we should have everything there with us. So, our contracts read that if we go into any building, right, that has 2 or more floors, we will both, so both private and fire, will both bring our jump kits, right? Anytime you guys go into the airport, you guys will both bring your jump kits. Any other time, it's just gonna be the first arriving person.
Airports, and second and third floor.
Mm-hmm. Mm-hmm.
Otherwise, just the first person to get there.
Correct. First 5 minutes, you should have everything there, and it has at least one of everything that's in the truck. Right? So you'll have one adult BVM, one pediatric BVM, right? You'll have one of every size OPA, one of every size NPA. In the truck, you have enough for 2 critical patients. Make sense?
Mhm.
So your jobs are going to be, let me put this right here. Let's say this is going to be your kit. And you run on a diabetic patient. So you guys use D10, right? You guys set up an IV, so you guys use an 18 gauge out of your bag. You guys use, we'll say, a liter bag as well. Let's say the person had a low blood pressure. And you guys use a macro. You guys use a tourniquet, tape, and some gauze. Your jobs as EMTs, or even AEMTs, and this is just the way it is, right? Falls back on you, as now your medic partner is going to be typing, right? Doing the report. You guys, before you guys go into service, you guys take an inventory of everything that was used in that person's home, restock it from the truck to go in here.
Yeah, I saw that happening on Friday.
Perfect.
The firefighters took it from the private ambulance.
Yes. And that's part of the contract as well, right? Fire will always be, because they have a different setup, right? We can have supply come and meet us with extra stuff. They don't have that luxury, right? So that we restock them.
Right. Yeah, that was awesome.
Mm-hmm. Yeah, it's a good working relationship.
Mhm.
But then if that happens, if you guys are now both working out of your guys' bags, and you're not sure what was used, hey, was that 18 gauge out of ours or out of theirs? Right? You have to take a second, go through, do a quick inventory, and throw another one in there. And sometimes that happens.
Something I saw a firefighter, the other day at my job, had this giant backpack or something. I was
Mhm.
like, what is in that huge thing? And it's like, you know,
Mhm.
these jump.
Mm-hmm.
Big.
All right, find what page. Let's talk about how oxygen and how carbon monoxide interact. So find the page that carbon monoxide is on.
What do you want from carbon monoxide?
How does it work with the blood? And we're gonna add this one. So this one is number 11. We're gonna add that with
Combined with the hemoglobin.
combines with the hemoglobin. What page are you on?
We're looking at 57.
57. So page 57. And I remember writing something else that was about blood. Okay, this we're also going to talk about with 60. With point number 60. So 60 and 11 are going together. So, if this is now a vessel, in here we have different parts of the blood, right? What pages are the parts of the blood in? And may I see your phone again? Or your YouTube? Or not for you. Do you have Pinterest? I wonder if I can get my Pinterest.
No, I took that.
Let me see if I can just search it.
What did you say you needed again?
The parts of the blood. Alright. And save image.
Taken from
I'm sorry, I'm going into your. I should have told you. I was going into your thing, but everything's
cool.
dressed. Sorry.
Totally fine, yeah.
Sorry. I copied it. Why isn't it?
Those are my clients. That's your fine.
Okay, here we go. Alright, so on here you guys will see that in our blood, right, we have different percentages, right? So you have your plasma, you have your erythrocytes, and then you'll see that you have a very small percentage of your leukocytes, and leukocytes is a fancy word for what?
White blood cells.
White blood. Erythrocytes are going to be fancy words for
You
erythrocytes. Erythrocytes is red, leukocytes is white, right? So, hopefully this will help you guys remember. But if we can think of this as almost like a little ecosystem, like a river, right? Your plasma is going to be the water itself, right? And what page is this on in your book? The exact thing that I just sent you. So, just so I can refer to a page. It should be in the beginning. It should be close to 57.
What are you, what we're talking about right now, plasma?
Mm-hmm.
Oh, I mean, I'm looking at it at 203.
But,
But
so that this
There's-
picture is also in the book too?
Yeah. It's similar. A similar diagram.
I have similar as well. Oh. 207.
207 has perfect. So on 207. So 57, 207. Okay. So your plasma is going to be the water. If this were to be now a river, your red blood cells are going to be. You guys can imagine almost like a shark is not going to work. Have you guys ever seen the fish that it's a larger, almost like a whale? Let me do that like that. All right, this is gonna make more sense. My little analogy. All right, so these are gonna be whales.
Goldfish?
Big whale, right? And there's this little blowhole. Okay? Don't judge. Right? Blowhole. Right? And then you have your sharks. Right? You have your sharks in here. Your sharks are going to be your leukocytes, your white blood cells. These guys are going to fight infection, right? As they now go through the plasma. These big happy guys right here, what normally attaches to big whales? Have you guys ever seen a picture like this?
That's nasty.
I'm gonna borrow your phone again, just so you guys understand where my mind is going. And I'm sorry, I have a strange mind.
So the white blood cells fight infections.
White blood cells fight, right? Hopefully this analogy will help you. So there's a picture of, they're like little sucker fish that attach themselves to those whales, right? And these guys are big, and that's why I want you guys to think of like a whale. They're big, they're round, right? Like a big old whale. And they're round because if they now bump into each other, they just bounce off. They're perfect, right? So if you guys can imagine him coming over to here, he's not going to get caught, right? He just bounces right off. And he now has these little sucker fish that are attached to him. If you guys can think that these are now oxygen, right? They now stick to the heme, right? Heme, if you guys can imagine, is now the skin on a whale, right? That these little sucker fish are attracted to for whatever reason, right? Why those little fish are attracted to these guys. Same thing is happening here. So the skin on this whale is heme, and these little guys want to stay, and this is O2. Okay, so without good heme, right, you can't have now a good attraction. Does this make sense to you guys? Right? If now there's a break in this little ecosystem right here, right, we're going to have some sort of coral or some sort of dam, right? And that's going to be your platelets. Are we all good with this?
Mhm.
There's
To prevent from clotting?
to prevent blood loss,
Blood loss, right?
right? So let's say this guy was shot, right? And now he has, let's say his normal ecosystem has 1,000 whales in it, just for numeric value, right? He was shot, and now he just lost 500 of his whales out here, right? Do you think that it's possible for this guy to still have a good SpO2? If the SpO2 is just measuring how much saturation is there? Yes.
What was the question?
So the question is, he's lost half of his whales, right?
Mhm.
So half of his hemoglobin's out here. But the SpO2 is just measuring how much is saturated,
Oh,
right? So the 500 whales that are still in here are still fully saturated. So you can have a 94 and above SpO2, right? But this guy's cool, pale, diaphoretic. So don't always put all of your attention on a number, right? Look at the whole entire picture. Understanding that, yeah, he has a 94 and above SpO2, but I see that he's sitting in a pool of blood, right? And that blood has whales in it, has hemoglobin, has oxygen out here. It's not in here, so I have to put him on 15 liters.
so technically
He's cool, pale,
oxygen-
diaphoretic.
Oxygen is separate than hemoglobin.
Oxygen attaches to hemoglobin,
Right.
okay? Does this make sense to you guys? Are we all okay? And if this analogy for people at home are like, what the heck is she talking about? I can try to change something up. But for the three of you guys who are in here, we're okay?
Yeah.
Now imagine this, right? So this is one sucky fish, right? One breed. Oxygen, right? There's another sucky fish that is even more attracted to these guys, right? And that is carbon monoxide. Carbon monoxide will come over and I'm gonna make these little sucky fish. They go all over like leeches, right? And they will bump any of these guys off the hemoglobin. They will bump the oxygen off and totally saturate, take over the entire hemoglobin and not allow any oxygen. Think of it like this now. SpO2, when now somebody has carbon monoxide poisoning, what is their SpO2 going to be?
The same.
What? What do you mean the same?
it's gonna be fine.
It's going to be perfect.
It's gonna be-
It's more than likely going to be 100%
Mhm.
because their hemoglobin is 100% saturated. Does this make sense? But their oxygen level is poor, so their brain is starving. Right, so be very careful. What page did we find our CO? Carbon monoxide.
Like 47?
57, I think, was O2, and then it goes to the hemoglobin.
Oh, 57.
57's on it as well.
Mhm.
CO.
Yeah.
Okay, so make sure that you guys understand that CO is how many times more attracted to hemoglobin on page 57.
Page 57?
Is that what you guys, the carbon monoxide's on 57?
Mm-mm.
That was a 200.
Oh,
Not 0, sorry, it's different.
oh, it's different? Okay. We're just looking for, people at home, we're just looking for the CO.
So. I think it's 400.
403?
Yes.
Okay,
Yeah.
so page
403.
403, guys. You guys want to read about the attraction. So on page 403, how many more times is CO attracted to hemoglobin? Do you guys see it?